It is just a huge honor for me today to be podcast interviewing Judy McIntyre, DMD, MS. She's an endodontist at Hopkins Endodontics in Hopkins, Massachusetts. Growing up in sunny Los Angeles, California, Judy wanted to become a dentist ever since she was a little girl. She attended the Harvard School of Dental Medicine, where she graduated Magna Cum Laude. I'm so dumb, I don't even know what that means. At Harvard, she performed research on dental unit water biofilms. After graduation, Dr. McIntyre obtained a coveted endodontic residency at the University of North Carolina at Chapel Hill. Alongside renowned researchers in the field of endodontics, traumatology, and pediatric dentistry, her thesis and research regarding traumatic dental injuries, her true passion and great interest, has been published in numerous professional journals. She's worked in private practice in the South before returning to Massachusetts. After completing the Massachusetts Dental Society Leadership Institute, she remains active in the society. She resides locally with her family and rescue dog. She enjoys spending time with her family and friends when she's not in the office. And it's just a huge honor for you to be on the show today because when you go to your website, hopkinsendodontics.com, and you look at all the papers that you publish, I mean, you've been published in PubMed more than most of my friends have even logged on to PubMed, but they're all dental traumatology, permanent tooth implantation after evulsion, root fractures in children, elementary school staff knowledge about dental industry, effectiveness of dental trauma education for elementary school staff. You're almost like an endodontist and for pediatric dentist.
I do see quite a bit of children, and I'm blessed that most endodontists don't want to treat kids. So, that has sort of become my informal subspecialty. Obviously, as a mom, I've been able to handle a lot of children with finesse. I really take a lot of pride in the fact that I don't even have a nitrous sedation certificate. I am able to, I know how to give nitrous, but honestly, I figure I can rationalize with most kids that are 7 years old and up. I've done 1 6-year-old, all anesthesia. Most of them don't even tear up for me. I just have sort of a way that I get them to I convince them that we need to fix their tooth and I need their help and we're going to do it together.
That is so amazing, and it's just an attitude. I had my mind open on this when I podcast interviewed a dentist who does hypnotism, and he was from Ireland. No, he's from was he from Ireland or Scotland? And he said something that blew my mind. He said, "Well, Americans don't treat patients with anxiety." I'm like, "Yeah, we do. We put them to sleep." He goes, "That's not treating them. That's just knocking them out. And when they wake up, they're still afraid of the dentist." He goes, "I'd rather spend the time up front, get into their head, build trust, get a relationship going, and treat the anxiety." And that's what you're saying. You're saying, I don't want to knock these kids out.
It's really amazing. Yeah. I mean, sometimes I'll actually ask the parents to leave so that I can work, and it's successful. I just really, really thank the kids for their confidence and trust when we're done, because they allow me to do what I need to do. And it's amazing. But yeah, parents sometimes aren't that helpful.
Well, this is Dentistry Uncensored, so I don't want to talk about anything everyone agrees on. I want to get right to the controversy. When I was little, all the gynecologists and OBGYN, they were all men. Now they're all women. And in my 32 years being a dentist, I'm seeing pediatric dentists shifting from all male to some of these graduating classes and specialty programs have 6 students and 5 of them are women. Do you see pediatric dentistry turning into a female specialty?
I know quite a bit of female pediatric dentists. I'm an endodontist. I would say now in pediatric dentistry, I probably do know more females than males. And in endodontics, I would say it's still about half and half. But yeah, that's totally unofficial.
I mean, I got 4 kids and they've turned into 5 grandkids, and I would rather go take my grandkids to a female pediatric dentist than have grandpa do it.
You have smaller hands, so those are good for root canals. I always think about that. I do get a lot of compliments about how gentle my anesthesia techniques are, and I don't know, maybe it's because I have small hands, maybe it's because I'm a female. Who knows?
So what do you think that the listeners listening to you today don't really think about traumatic dental injuries and endo? Like an endo, I mean, I think of endo as a bacterial invasion, a cavity got into the nerve. That's pretty much all the root canals I see. What percent is traumatic dental injuries leading to endo? Is that 1% of the root canals, 5%? What do you think? How prevalent is that?
So I loved your question just now because you gave me kind of an aha moment in terms of traumatic dental injuries and endodontics, really, because what I try to tell my referring dentists and what I try to tell my general dentists is both of them need to have that perioperative conversation to understand and lay the foundation down for what's coming. We don't know what's coming, whether a tooth is going to need a root canal or in a traumatic dental injury, if it's going to be able to be saved. But you've got to have that initial conversation first to anticipate so that when something unforeseen happens, like the root canal being needed in just plain operative dentistry, restorative dentistry, prosthodontic dentistry, and with dental trauma, people aren't so hysterical about it, excited, not in a good way about it, or when they abscess. All of those things, if you have the conversation beforehand, then it's not such a big, unforeseen, surprising event when it's needed. Overall, dental traumatic injuries affect 20% of the population. That encompasses all of the injuries. So we're talking about, enamel dentin fractures, pulp exposures with the fractures. But in terms of the injuries that require endodontics later, most of those would be the luxation injuries. And of course, 100% of the avulsion injuries will necessitate endo. Absolutely do not pass go, do not collect $200. You need a root canal if your tooth has been knocked out. And you'd be surprised at how many people still don't realize that. And the dentist will tell them, let's watch it. There's only one scenario where you watch. Yes, it's true. It's true. The only time you're going to watch an avulsion injured tooth is with an open apex, usually 2 millimeters more open radiographically. Otherwise, do not pass go. Root canal. Root canal within 7 to 14 days, always, 100% of the time.
Wow. And not to get off topic, but a lot of these injuries to anterior teeth that end up needing a root canal, it's also almost everyone puts a post in it too. But it's like when you study posts, I mean, you almost could come away thinking the only indication of a post is if you want to further fracture the root. So what's your view on these traumatic injuries and post?
This is actually right now kind of a lighting up topic on Instagram in terms of endo and restorative issues. So, right, we both learned that you need a post to bridge the restorative to the root. If you have enough tooth structure, you don't need a post. So again, I completely agree with you. These posts, the larger posts, the cast posts, the screw posts will tend to fracture teeth, both anterior and posterior. In anterior teeth as well, I believe there's a movement, positive movement towards using fiber posts. And, we don't always have to put that post in. If there's 3 or more walls remaining, if there's the ferrule, I just challenge everyone to really assess whether a post is needed.
I think the most interesting thing about a ferrule is that word comes from barrel making. That was on a 50-gallon barrel. That was that little metal collar around that. And they figured out eons ago that if you put a little metal ferrule around the barrel, a barrel ferrule, that the barrel was, 10 times stronger. And then they started moving it to one at the equator of the barrel, then one about halfway up and one halfway bottom. And so a barrel maker knew everything about ferrules, hundreds of years ago, that dentists are still having a hard time understanding today. It's your bonding agent isn't going to keep that crown on. If that restoration doesn't have a 2 millimeter ferrule all the way around it, you're kind of in trouble. Instagram, she's Dr. Judy Endo. You know why you're on Instagram? You have a face for Instagram. I have a face for iTunes. So you can do all that public stuff on Instagram. Before we pass, traumatic dental injuries. Is there anything you think my homies need to remember most? I mean, is it still the same thing? If you can get the tooth and hold it in your mouth until you get to the dentist, is the best bet?
I would say that's probably second best, with all due respect, because in the mouth, in the cheek, it can still undergo injury to those delicate PDL cells. So what I would love is to find a cup, find milk, or, school nurses might have those Save-A-Tooth kits that are just like this big, and they're $20. Some coaches might have them. I've posted on Instagram, I drive around with a Save-A-Tooth kit because I'm that type of person that always anticipates that injury. But the Save-A-Tooth kits are really inexpensive. I donate a few every year to my local school nurses. Milk, even if it's shelf-stable milk like Parmalat, that milk is good. Cold, preferably, skim, preferably, in a Ziploc bag, find the tooth, put it in there, get to your dentist. Siblings are the best bet for replantation. They're amazingly confident. Hysterical moms just won't rise to the challenge, but give that tooth to a sibling and they'll be happy to put it back in. In terms of everything else, just, after the emergency room, if the emergency room and physicians have been involved, if the emergency room has given their blessing, get to the dentist. Even little types of injuries, you should always have that baseline exam to make sure that we know what we're starting with, so that should a tooth necrose later on radiographically change or aesthetically change, then we know at that time what it looked like at the day of injury. And then from there, we can compare. A lot of people don't understand that we need that comparison, and that is beneficial information so that we can watch the progression of any changes.
Well, it's probably hard for you because you're up there in Boston with all those Irish people. They probably bring the tooth in soaking in Jameson whiskey and think they did everything right, and they don't have milk.
As long as it's not water.
As long as it's not water?
Not water. The water, because it is, the cells are hyperosmolar, so they will burst when placed in water. So that will cause more destruction. So again, something like saline, obviously what's best is like a storage medium like the Save-A-Tooth kits, because they're neutralized for the cells. And for whatever reason, so is milk, but not water, not dry. So again, if your cheek is your third best option, put it in the cheek and get to the dentist.
Wow. And you just said something that is going to seem so silly 100 years from now. Like you said, at the emergency room, the emergency room doctor wants you to go see a dentist. It's just so insane that 8.5% of emergency room visits are odontogenic in origin, and they could remove a brain tumor, a bypass, they could, do a liver transplant, but they can't touch a tooth. And then these DSOs, why isn't the largest DSO in America the chain that just has a dental office in every emergency room of every hospital in America? And the only thing they do in Phoenix, Arizona is they give you Vicodin and Pen-BK. And then, that's it.
Serve it, because that doesn't help anything at all. And the doctors, unfortunately, because the rest of the body is able to heal, physicians generally don't understand that, because the teeth can't heal, right? If a tooth could heal, would I have a practice? Would I have a specialty? No. The tooth is the only part of the body that cannot heal after significant injury. So I'm not sure if both patients and doctors need a lot of edification in that area, but yeah, the Vicodin is just not going to help, and neither is the antibiotic. Will help temporarily most of the time.
Yeah, and I've read so many papers posted on Dental Town that a good chunk of people addicted to opiates, they got their first dose at their wisdom teeth extraction.
Third molar extractions, absolutely.
Yeah. It's like, when did you try heroin? Oh, when I got my wisdom teeth removed. Well, was trying heroin a good idea? I mean, if you said to any mother, hey, do you think your daughter at 18, just try heroin just one time? Everyone would say, absolutely not. That's a really bad idea. And then that's what we do all day long.
Well, and the 30 pills, I had my wisdom teeth extracted. It was an uneventful, insignificant extraction I ate the same day. Of course, I understand there's more complicated ones, but really Advil and Tylenol, the literature shows is shown to be more effective. And, we definitely, if we're going to prescribe, you've touched on a lot of points here. We just got to do it a little bit more responsibly. I'll write for 4 tablets, maybe 5, but you need to get that tooth either extracted or started with root canal therapy pronto, and you only need 4 tablets for it to get you to wait through the weekend. You don't need anything more.
I tried one time writing for 4 tablets, and she just added another 4 in front of it. And the pharmacist said, "Are you really prescribing 44? True story. But anyway, we just had almost 6,000 kids graduate from dental kindergarten school last week, and they're coming out here. And again, this is Dentistry Uncensored. I want to talk about the real confusion in the marketplace. Is they go to the convention. There's like 100 different endodontic file systems, and they're like, come on, Judy, you're an endodontist for decades. I mean, you're published in PubMed and have that Magna Cum Laude things. They don't want to figure out all these endo files. And then their cynical part, which I love when I hear, is that they're like, well, Howard, it seems like every root canal training seminar you go to is sponsored by the dental endodontic file manufacturer. So it's almost like they're smart enough to realize maybe before I start learning about what you want to say about this file, I need to know which file system I could use because the continuing education and the people selling the files is so united 1-to-1. I mean, do you agree that a lot of the endodontic file seminars are corporate sponsored and could be biased to their own file?
Absolutely. And, we can't do a lot without sponsorship, so I'm not going to totally dig that. But really, I think the crux of your question is, how do all of these graduating students learn what might work for them? And really, I honestly just clicked this year at the AAE meeting in Toronto when I was chatting with a few colleagues, and everyone, the companies make endodontics look like see, can, do. Try one, do one, and you're practically an endodontist, and you should do, first and second molar root canal. I can tell you, it's rough out there. Any molar, some premolars that I get, it's tricky. You've got to be able to feel within the canal system what you're doing. It's not about one file system. It's about knowing what you're doing and feeling the pathway to lead you to the apex. If you can't feel it, then you shouldn't force it, and it should go to an endodontist, because even the most expensive file system, even the best file system, is not going to give you a pretty root canal if you don't have a mastery of what you're doing and what you're feeling and what exists within the tooth's anatomy.
Is CBCT becoming the standard of care? I mean, can you just really, like back in the day, have a PA and that's, you look for all the canals? Or do you think a CBCT getting a 3-dimensional image of trying to make sure you know the anatomy, is that standard of care?
So standard of care is a tricky definition. And, I know that all of our associations, especially our specialist associations, when I sit on these committees, using the word standard of care can get a little tricky. I believe a rubber dam is standard of care, but I'm not sure that cone beams are standard of care. I would love them to be, because they are so informational and diagnostic and helpful. But I just know that a lot of practitioners don't have cone beams yet. So I think, though, the meat of your question is, how have I found it helpful? I mean, in pretty much all of my retreatment and surgery cases, I explain it to patients as a roadmap, right? Your root canal failed for some reason, and I need to figure out what that reason was. Is there a crack there? Is there a missed canal that 2-dimensional X-ray is not showing me? Is there a missed root there that is just, kind of hidden? Or is there a lateral canal? There's so many things to keep in mind, again, with endodontics, that the cone beams are super helpful. The surgery options. If I'm doing a premolar or a second molar or a first molar, I want to know where that inferior alveolar canal is and the mental foramen is. So totally helpful. I'm not going to guess on a PA as what I think might be, a radiolucency that is just a shadow or an artifact. The cone beam has been super helpful, especially all the extra funny, funky cases that we endodontists get, which is quite a few.
Which CBCT cone beam do you like for molar endo being an endodontist versus someone else like an orthodontist who wants the full face and skull for ortho? What do you like?
So, without being too advertise me, I have a Cavo Kerr cone beam. I think that for most endodontists, the focus though is on the resolution. So it's that smaller field of view. I take most of mine are 6x4, and I do it at an 85 micron resolution. So that gives me the most information of what I need. It's not 100% diagnostic. It doesn't detect all fractures or cracks within teeth, but it's super helpful and can suggest all of the possible reasons why a root canal might be failing, or help determine me and the patient thinking about how to treatment plan a tooth that is failing or needs surgery. It will give me a better conversation to have with the patient in terms of success when we're discussing two different treatment options. I believe most orthodontists, obviously have the full head. I want to say that they use Plan Mecca, maybe. I'm really not sure, to be honest.
So on the Cavo, you use the Cavo on their website.
Yes.
They got the Cavo OP3D with SAF. I imagine that's for the orthodontist. They got the Cavo OP3D. They got the Cavo OP3D Pro, and then the iCat Flex V series, the first line. So which of those four did you get?
The OP3. I have the OP3. So the earlier version, which is it was actually called a Gendex Pro.
Oh yeah, they bought Gendex. Yeah, because that's owned by Danaher out of Washington D.C. and they just own all these. So you have the original Cavo OP3D, and then since
it was the last version before Cavo rebranded. So a very recent. It's only 2 years old, but yes, it's already old.
Yeah, and that is amazing. And then they have the iCat Flex. So the
iCat is very popular among a lot of practitioners, a lot of dentists, a lot of general dentists, restorative dentists. Yeah. And Cavo also makes the Nomad, which is super helpful.
So then Danaher or Cavo owns iCat?
Yeah.
Do you know how long have they owned iCat? Do you know that? Or
I don't know, but I know that when I call my rep, which is pretty often, he has the option for the Nomad and the iCat. So I want to say all this happened quite recently, but I'm not sure. I'm not on the cuff of the market in terms of CBCT.
So what would you say the top 3 reasons are that you like a CBCT? Is it mostly just making sure you're not missing a canal? I mean, isn't that the number one cause of root canal failure? You just miss an entire canal.
Yes.
So it's anatomy first, or what would you say?
It's anatomy. It really is anatomy, because the general dentist usually has obviously gone in there before me. The root canal has failed for whatever reason, and I need to figure it out. And usually there's a missed, obviously in what I see, usually it's a missed MB2.
And which two? Upper first molars?
Maxillary molars, yeah.
So what percent of your practice would you say is retreat of MB2s on maxillary first molars?
That's pretty specific. I would probably say maybe 10 to 20%, but I'm not fully prepared to answer that question, but probably 10 to 20%.
So kids, there you have it. I mean, you don't want to hurry up and get an A on the wrong diagnosis and treatment plan. I mean, if you want your doctor to do anything well, it's the diagnosis and treatment plan. I'd rather them get the A on the treatment plan and a C on the treatment than get an A on the treatment and it's the wrong treatment. And so it just missed anatomy. I mean, that's.
Well, when you think about it, those tooth studies are there for a reason. 98% of maxillary first molars have that MB2. So if you're only finding 3 canals, then, chances are that you've probably missed one, when you think about the statistics again.
So say the statistics one more time.
So 98%, it's as high as 98% of maxillary first and second molars have an MB2.
Wow.
92 to 98. Yeah. I mean, it's the high 90s. So they're there. And most of the time by the time they get to me as an endodontist, I will say that a lot of them are calcified. They're not easy to get into. I will trough with ultrasonics, use my microscope. I'm working hard on these. They're not easy. And they're hidden sometimes, and they're not where you expect them. I mean, most of the time they are where I expect them, but if you're not anticipating it's easy to miss.
Yeah. And, that's what I always tell, when orthodontists are afraid of like Smiles Direct Club coming. I said, well, they'll take over the whole industry because when you go to work, you don't really do anything and you're just sitting on the computer and it's just a real easy, lazy day, right? They go, no, I work my butt off and at 5 o'clock, I'm exhausted. And I said, that's why it's not as easy as it looks. So, I mean,
right.
There's a reason there's 4,000 endodontists out there. And the thing that general dentists need to learn is, pick the low hanging fruit. I can do a lot of things, but I certainly don't want to be a jack of all trades. I mean, it just doesn't make sense. There's also a new, but go back. I want to hold your feet to the fire. She's driving to work right now. And she says, come on, Judy, just tell me what file system do you use? I don't want to go. I mean, like if you go to Cologne, Germany this last year, there were 400 different implant systems. She doesn't want to look at 400. How many endodontic file systems do you think there are?
All right. So if I were to suggest to focus on the low-hanging fruit, the obvious cases, the anteriors, the bicuspids that general dentists want to try to do, the straightforward ones, not the 3-canaled premolar ones. Please don't do those. But I would, even as an endodontist, I use my K files first. I work everything up to a 15, and on calcified canals, that's not easy for an endodontist even. So I start at 6, 8, 10, and then 15 K files. And then what I loved when I was in residency and, in the general dentist setting for easier cases, I loved profiles. They also have the Series 29. Dentsply makes those. They are just straightforward, very safe files that just really are very resistant to fracture. I can't say enough good things about them. I used them for a decade. They're a great file system. I would say I don't use them anymore because I just don't have those easy cases anymore. So I need something more aggressive. And then, make sure you clean. For anteriors, you should be ending for the most part on at least a 40, 50, 60. I mean, a 20-sized finishing on an anterior tooth is just not anatomically correct. You're trying to put, a Bigfoot shoe on a child. Like you've got to match the file system to the canal, the finishing file to the canal systems with. So otherwise you're not cleaning. Like you said, very basic, clean. That's what I do. I'm a glorified cleaner.
So when she's talking about Dentsply, that's now, and got married with Sirona. So now it's Dentsply Sirona, but Tulsa Dental was because my buddy Ben Johnson, who started the Thermophil endodontic files, he was an endodontist in Tulsa, Oklahoma, and but I can say this because he's my buddy, and he wouldn't care. The counter argument about these rotary files is too much tooth destruction. There's now a lot of people are saying we're weakening the tooth.
Okay, so I'm glad you asked and clarified. I hope I just didn't cut you off. So I have always been an 04 taper girl. That's what I kind of refer to myself as often. So you have the bigger file systems. I'm just going to name one off the top of my head, and I'm not bashing here, but pro tapers conventionally have had the variable tapers, and their preps look like this. The profiles, when you buy the 04 series, because I'm an 04 girl, you're conserving the root structure at the top, the cervical dentin that is so important for the restorative dentist. And I've actually been saying this for a decade and a half. That is super important tooth structure. And I love that root canals can look so pretty with the variable tapers, but there's no reason to take that much of the cervical, the radicular dentin away. We really should respect that tooth and respect the restorative options. And I believe as long as you're cleaning well, consider the smaller tapers, consider the 04 taper. I finish on 04s, and I would like to say that I'm extremely successful. I don't retreat my work very often. And you've got to consider the fact that when you remove excess tooth structure radicularly, that's what leads to fractures, strip perfs, weakening of the tooth structure. And then obviously when there's a post that's added to everything that's just been taken away, the tooth gets very weak. We've got to respect what we were born with, what the patient was born with.
I've noticed, so with Dental Town, with 250,000 members since, 99, and 67,000 have downloaded the app, I can see what they're searching. And one of the first correlations that we've noticed way back into the 90s is that the more money something costs, the more time they're going to spend searching. I mean, who cares about trying a new bonding agent if it's, $50? But when you're going to go buy a CBCT or a CAD cam or something, something 6 figures, they're like, I want to make sure this is right. There's a new expensive Son Endo. It's almost like hooking this tooth up to
$70,000.
Right. So I want you to talk about it. $70,000 worth of information, because again, if it was $70, she wouldn't care. She would just buy one and try it. But for 70 grand, she really wants to know if this is a good idea. What are your thoughts on this?
So I can't speak much to it because I don't have one, but I have seen the cases because I am always on Instagram and I follow a lot of my friends and other Instagrammers who have the Son Endo. And I must say I am super impressed with the way it cleans, the way it respects the tooth structure, the dentin, the way it gets into lateral canals that even as an endodontist, I might not be able to get into. It looks like an amazing cleaning machine. I don't have one. My friends that have one eventually do love them. There is quite a steep learning curve. I mean, generally, us endodontists in particular, because we're so unique is what I call us, we're creatures of habit. We, any change kind of unruffles all of our feathers. So there is quite a learning curve to it. But I also know that it will supposedly reduce the post-op sensitivity that a lot of patients have, and it really allows a lot of the retreatments to be done in one visit. I do my retreatments in 2 visits, so it obviously is a very positive thing. I'm just not at the point where I can afford one quite yet. So,
and what she just said to me is, I've been doing this 32 years. There's a distinct difference between high price bleeding edge, and we're still not sure, versus leading edge, and the early adopters start buying it. And so many times in my early 5 years out of school, I tried something brand new, and end up having to, they all failed. And so now when you're an old dog like me, when we see this new exciting stuff, we are so excited that all these young whippersnappers are going to go try it all, and we'll just sit back and smoke a cigar and just watch. And then 2 or 3 years later, the price comes down and we determine if it's a good buy or a bad buy, but it has to be bleeding edge versus leading edge because you haven't bought one and you're an endodontist in big city Boston.
Well, the price of it actually has gone up, from what I understand, about $10,000 over since it was originally released. Now being a decade and a half out, I have also seen things come out and fail. And yes, there is some literature on the success of Sonendo, but it's not independent research. So I completely respect what you're saying. We'll see. Time will tell, right?
Yeah, but it's exciting to you, but not enough to go exciting. Whip out your checkbook and pay $70,000 yet. You're not. Is that a fair assessment?
I also have a smaller practice, so yeah. I'm just not there yet where I can introduce that into my practice.
And so it's so bizarre when you're listening to dentists talk about root canals. I mean, the first question that comes up is, what are you obturated with? And I'm always sitting there and thinking, who cares? I mean, my endodontic instructor, you say, if you find all the canals and get them all cleaned out, you could fill them with bird doo-doo as long as you autoclave it first. Why do dentists always talk? Like they'll come up to me and they'll say, well, what do you think of thermophil? Back to Ben Johnson. It's like, what does thermophil have to do with the root canal? Did you find all the canals and get it all cleaned out? What is this obsession with obturation?
I don't know, but it's still endodontist's obsession. Warm vertical, hybrid, cold lateral, a little bit of all of the above. Now there's all these bioceramic materials. I mean, everything. It's just always exciting. We're always, I guess, trying to challenge ourselves as a profession to do better. I don't tend to obsess too much about what I fill with. I have changed my sealer in a decade and a half. But again, I want to wait for things to prove themselves to me to be successful. So
did you switch from Grossman cement to some new bioceramic thing?
I did. So I had started and used Grossman's Roth, if you will, for many, many years. And then I used AH+, which I really loved because I could mix it however I wanted to. Same with Roth, but a little different. And then, I just started using the bioceramic sealers, which, are very user-friendly, antibacterial, I want to say osteogenic, but the word's not coming to me. It's just, again, a great material from what I can read in the literature. So I have moved on to that, and I'm excited with how everything looks, I guess, is how we grade ourselves in terms of endodontics.
Speaking of looks, a lot of, like I say, dentists, I mean, you go out drinking and watching a ball game and, when endo comes up, it's, what do you obturate with? And some of them are so obsessed with the obturation, like some of them, we call them apical barbarians. They want to get all the way to the bottom with a puff of sealer out the end. And then you got these pulp lovers who want to stop a 0.5 millimeter short and make it look all pretty. Yeah. Are you an apical barbarian or are you a pulp lover?
So I was trained at North Carolina. So we were taught there. Dr. Martin Trope, Dr. Asgeir Sigurdsson were both there while I was there. So we were taught to not violate that apical foramen at all, and that, a 0.5 millimeter shorter was better. So we were truly taught not to puff. We were taught that
not to puff. Are we talking cigarettes or root canals?
Both. So we were taught that, the puff is a violation of that apex, which is not supposed to be. Everything beyond the root canal, the apex of the tooth, is not our territory. We're supposed to clean from within, so decrease bacterial load from within, and do everything in that contained system, and to not, what did you call it, apical barbarian? Not violate that closure, that restriction.
He is.
So I tend not to puff. Sometimes in lucency, I will try now, but I'm a decade and a half, and we're not supposed to tell anyone about that. I'm also in Boston. Boston is a puffy kind of place. So here the residency programs encourage puffs. Shoulder was here. It's all about the puffs here. So sometimes I know that my referring dentists, like to see the puffs, but I generally was taught not to.
Martin is a heck of a guy. He was on the show, episode 305. He's made some endodontic CE courses on that. Back to these kids who just got out of dental kindergarten school, because seriously, when you look at the data, and send me an email, howard@dentaltown.com, and tell me how old you are, and what country you're from, or the comments on YouTube. But a lot of them, they have a hard time talking about root canals to patients. I mean, the most complicated skill you're ever going to have in life is talking to other sapiens on the surface. And I remember the endodontist a few years ago, but I thought it was laughable. They wanted to stop using root canal and use endodontic therapy. And then the inclusion people wanted to stop using TMJ and use TMD. And it's like, hey, why don't you just all speak Greek? I mean, if the humans all call it TMJ, and I'm treating humans, I'm not a veterinary dentist. If you come in and say your TMJ hurts, I got to talk TMJ. They talk about root canals, and it's not a pleasant. No one wants a root canal. So talk to these little kids about how do you talk about scary stuff like root canals, and And
I feel like this is so important for the restorative dentists who then refer, because when you don't have that proper conversation with the patient can get really upset. And of course, no one wants to hear that they need, quote unquote, a root canal, because apparently those words are so terrifying. But little plug here, modern day root canal therapy or treatment is not scary and it should not be painful. But restorative dentists that are replacing the MOD amalgam, that see the pulp horns shrinking away from their restoration, you should have that conversation. Hey, if we're going to change this restoration, hey, patient, Miss Brown, if we're going to get that crown done, maybe you should have a consultation about needing a root canal before we place the crown, before we change that restoration. Hey, let's take a periapical film of this tooth before we change the restoration, because it might be dead already. All of those things, if you just lay the proper foundation to the patient, have that 1 to 2 sentence conversation, it's not a surprise when they need it, when you tell them. And it can avoid a lot of hard feelings that might result when eventually you as a dentist have to say, I think you need a root canal, right? Because that's so much more surprising than the precursors, the little laying the foundation in terms of a conversation beforehand. And
I want to also tell you one thing about how humans work is if I tell you I'm going to do a filling and then halfway through I tell you it's going to need a root canal, I am a very bad guy. If I tell you you're going to need a root canal and crown, and then after I get all the decay removed, it turns out I'm just going to do an MOD composite, now I'm Batman, Superman. So and then when you treatment plan, I warranty everything 5 years. And so I've had associates for 32 years. And a lot of them treatment plan, and it doesn't last a year, and they say, well, I tried my best. Well, dude, the person's going to live 85 years. Are they supposed to come in here and drop $1,000 every year for 85 years because you have no idea what you're doing? So you have to treatment plan aggressive enough to last 5 years. Hell, at 85 years, that tooth's going to need a lot of additional treatment, but it's got to last 5 years, and you got to diagnose aggressively enough. So in my practice, when someone says, Judy, you're just going to need a filling today. And then you do the FA, and it's for $250 for an MOD filling. And then 30 minutes later, your baby dental kindergarten school mentality says, oh, I changed my mind to a $2,500 root canal billet and crown. Then I say, well, guess what? You're going to do it all for the fee of a filling, because that's what you told Judy she needed, and she was only prepared for a filling. And if you thought it might have needed a root canal and a crown, and you're a doctor, you should have said that before. So satisfaction equals perception of what is happening minus what I expected. So common algebra says you want to increase satisfaction, you got to sit there and deliver, you what they are expecting. And I'm
Absolutely.
always the hero because I'm one of those guys that hold that PA at arm's length. And if I think it's going to be a root canal to arm's length, I treatment plan for a root canal. And then I hope I'm wrong. But you can't reverse those steps.
That's right. And again, I really post a lot about those pulp stones and the calcification and the pulp horn shrinking away. When you see that on the bite wings, you should take the PA. When you see that the whole canal is calcifying, I can't get down canals that are blocked. So it's always better if you have canals that are calcifying and you're planning to do that crown. There's a time and a place for prophylactic endo, because guess what? I'm not going to be able to help if they're completely calcified and then they abscess. And let's remember, usually a majority of crowned teeth will ultimately at some point during that tooth's lifetime need a root canal.
What percent?
I mean, the literature in school told me 80%. So that's 4 out of every 5 crowns needing a root canal at some point in their lifetime. Now, if you think about all the patients out there with crowns, obviously you'd think that can't be true, right? That just seems so low. I submit to most people, let's take the PAs. I'm pretty sure there's a lot of dead teeth out there that can surely fill up my schedule. The calcification process is a process of a live tooth in response to injury. If you see calcified canals, that means that tooth is not healthy. That tooth probably needed that root canal as soon as you put in that restoration, as soon as you place that crown. Now, we both know that a lot of times a patient can remain asymptomatic, but they might still need a root canal. Good for them, but that doesn't mean that they don't need a root canal. It means that they've just been lucky to be asymptomatic, right?
I am going to throw you off a cliff right now. All right? You have your parachute on and a helmet?
Absolutely.
So again, I don't ever want to waste anyone's time talking about everything everybody knows, but there is a serious, and what you just said about, the infection coming in the tooth and the pulp is trying to save itself by laying down dental tooth structure and receding from that pulp. So there's pediatric dentists saying, you don't need a pulp on a crown-still crown. It's doing its own pulp on it. Just use silver diamine fluoride and see them every 6 months and paint this stuff on. And you don't need to, the only reason you're taking them to the operatory and putting them to sleep and doing 6 pulpotomies and chrome-still crowns is because you're going to make $1 gazillion, but you have this anesthesia risk. You have this anesthesia risk. I'm talking about the young pediatric dentist. The thing they hate the most is when a 2-year-old doesn't wake up in the OR because she was put to sleep, and they're looking at that case. They're saying, first of all, I would have not even done the whole thing. I would have just delayed with silver diamond treatment. And it's a very emotional argument. So,
I am familiar with SDF, and I've actually placed it on my children's grooves and pits and incipient decay. I don't know, and again, I'm not a pediatric dentist. I don't know that really for the gross caries. I know, from what I understand, the gross, bombed out pediatric cases that you might be referring to, I think it will halt and terminate the active carious process, but that doesn't necessarily mean that a root canal can be avoided. If that makes sense. And I don't feel I really fell off a cliff there or was thrown off a cliff.
Well, if you are entered into this debate, you're gonna wish you never were entered that debate, because it's a very emotional debate.
We need films, because we're talking theoretical. We need to make sure that we're referring to the same cases, not primary teeth. I'm not talking about primary teeth. I'm talking about the first and second molars of children with moderate small decay, not big decay here, because the big decay ultimately without an open apex will need a root canal, not just SDF.
So do you think, just give me your thoughts on silver diamine fluoride. I mean, do you think this is,
I think it's great. I think it's so far great. I would love to see probably more literature from what you're saying about the bombed out teeth with SDF, whether they will ultimately avoid root canal therapy later in life.
And the other thing about this whole issue, the whole issue, the reason it's so prominent, again, when I'm hearing these people talking now, remember they're drinking, so they're under the influence, and but they just cannot stand this problem with pediatric anesthesiology. I mean, you're talking about board certified pediatric dentists with board certified anesthesiologist, and every few months on social media, some kid didn't make it out of that room. And then what you said earlier in the beginning is that, again, if you treat the anxiety and you start talking to these kids, I mean, you're almost always going to base what'd you say, 6 and over or 7 or over?
Generally, my rule is 7 and over. I had a great 6-year-old that, for whatever reason, she worked, but I've even worked on a 5-year-old without nitrous. But again, you have to feel it. You have to feel the connection. There has to be that consultation. But yeah, generally 7-year-olds and over, I don't need nitrous.
So again, framing this pediatric decay, a lot of people might use a lot of silver diamine fluoride to get a 4-year-old to age 7.
Absolutely.
And you're not treating the anxiety by putting, I mean, like Michael Jackson, he had issues and he was treating it with propofol, and it didn't treat the issue. And then he had a drug interaction problem, and now he's gone. And maybe he should have talked to a doctor about, is there any way to sleep without Propanol? And is there any way we can treat this 3-year-old without IV sedation and intubating them, and maybe we can delay decay with silver diamine fluoride until you're old enough to treat their mind. And so I want to tell you one of my pet peeves with my homies when they use endodontists. They're so, it just really hacks me off when they say, oh, you do the root canal, but I'm going to do the buildup in the crown. Well, you're fighting billions of bacteria. You just found all the canals. You cleaned them all out. You just obturated it. And now you're going to have to, I mean, isn't that the most perfect biological time to do the best buildup you can? And we're not going to wait 2 weeks so that you can build Delta Dental. I mean, I just wish endodontists would just say, it's not even an option. We're doing the buildup because we're not insane.
I mean, I think I just need to get that little blip and just put it on my webpage. You know, I mean, I would love to. I don't know that I would keep any of my referring dentists, though. But the referring dentists that I have are wonderful. I will generally, when I am concerned about potential contamination, a lot of endodontists that truly are concerned also will lay a pulpal floor composite over their gutta percha. That is a newer trend that, you know, is great in terms of the movement in the right direction. I worked in a general dentist's office for almost a decade. I would do the core, or I would send the patient under the rubber dam down to her chair, and she would do the core, but still under the rubber dam. And again, it's just, like you said, almost everyone should think of this light bulb. It's decreases chair time, decreases staff time, decreases patient time. It's too obvious. Why aren't we doing it?
So another problem that the young kids have is you know, they come out of school, you know, their mom made them. And your mom's your mom. I just had dinner with my mom last night, and she didn't understand my joke. I tricked her. I had her stand on the stairs, and I took a picture of me and my mom on the stairs, and I posted, this is my biological mother, but today, technically, she's my stepmother, because she was standing on a step of a stairway. And my mom said that was the stupidest joke in the world. But when they come out of dental kindergarten school, they go back to work with their mom, who's a dentist, and she just one-steps every root canal she does. And you don't want to argue with your mom. And that's one of the things they're stressed about, doing dentistry different than your mom. You're working for your mom in the family business that you've had for 3 decades. She one-steps everything. And sometimes they're like, so when do you one-step? When do you two-step? And if you did 100 molars, what, feet to the fire, how many would be one-stepped and how many would be two-stepped?
You know, This is going to be probably the most embarrassing answer to your question that you might have ever had. But I two-step probably 90 to 95% of my cases, just because what I am getting is either necrotic, abscessed, or calcified, and I just can't clean to my level of standards in one visit. So I'm putting a lot of medication in. I'm asking patients for their time and coming back. And I don't two-step much. I want to say probably in this past year, I might have one-stepped 3 cases.
Wow, that is so profound. So obviously she's an endodontist, so she's getting more difficult cases than your average routine bread and butter toothaches, but cleaning and shaping. And that's another trend. So when we switch from endodontics to the business of endodontics, the number one complaint I'm hearing from all these DSOs is that 10, 20 years in this DSOs, their endodontists are actually doing less root canals per day and spending more time. Like some of these DSOs say, God, 20, 30 years ago, our average endodontist completed 4 root canals a day and they booked an hour for each one. And now 20 years later, they're doing 3 a day and they're booking an hour and a half for each one.
It's true. It's true. It's true.
So as you switch from an American Chevy Chrysler Ford to a German Mercedes Benz, it's not a game of volume and they take longer.
They take longer. The reimbursement code for the challenges or whatever are generally not covered. I mean, we are working harder and definitely not smarter. It's just not the good old days of dentistry anymore. I work hard every day.
Okay, again, I'm trying to focus this down because the people on podcast, they're all 30 and under. If you're 30, 30 and a half, send me an email at dentaltown, howard@dentaltown.com. But another big question they always have at this stage of their career, right when they get out of school, is the apex locator says, I'm there, and the x-ray, it looks short.
Yep. This is one of my first papers actually was on apex locators. So I understand apex locators a lot. But to be honest, I use an apex locator almost every single time, and I can understand why there's faulty readings. To be honest, I feel when I'm at the apex because I've been doing this for a long time, right? When the tooth is alive, like has live tissue in it, or wet, too wet, or there's an amalgam, or there's a crown metal, it's not going to read correctly. So that's a lot of cases. Just take the film. The apex locator is there as an adjunct. It's not the panacea. So again, I think you spoke to it. Like we just want a guarantee and the easy way out. But what we do is not necessarily easy. So,
I hope these papers. I love your papers. In fact, if you go to Dentaltown, you go to Endo, you should start a thread. Because you can upload the PDF paper onto Dentaltown. Just like if you have a YouTube video, you can.
Awesome, yeah.
You can do that because and I notice you do a lot of these papers with my buddy Martin Trope, but it seems like you and William Van are buddies too. You guys do a lot of stuff together. Is that one of your endo buddies?
Tell me the name again.
William Van.
Bill Van. Sorry, Bill Van. Bill Van and I are tight.
Oh, you call him Bill Van. Okay.
Yeah.
So,
yeah.
So tell us about Bill Van.
He stayed at my house.
Really?
Yeah.
Huh.
Love him. We have a love for pets together. We love trauma together. We've published a lot of things together. He's a great guy. He's a great guy. Very knowledgeable.
I can't believe we went over an hour, and I love talking to you, and I could talk to you for 40 days and 40 nights. But I want to tell you another issue about the dental kindergarten schools is they say, Judy, I graduated with $287,000 student loans. I don't have the money to join the Massachusetts Dental Society. And the easiest $1,000 I'm going to save is I'm not going to get involved with the organized dentistry. And you're really involved with organized dentistry. I mean, this Massachusetts Dental Society. So what would you say to that 25-year-old girl who says, I know how to save $1,000? I'm not going to join the dental society.
You know, it's not for everyone, but there's a lot of perks to organized dentistry. There's a lot of behind the scenes that not every dentist, even the participating dentists in the dental society, realize. You get the discounts on insurance, you get the peer review, you get the journal, you get some travel discounts, you get a lot of the office resources from that the ADA might have or that the local dental society might offer. There's a lot of camaraderie. It is a hefty chunk to pay, but I feel that particularly with what we're faced in modern day dentistry, managed care, and the reductions in reimbursements, organized dentistry for me has got to be our saving grace. Because, you know, I hate to be a Debbie Downer to the kindergartners, but it's just not the good old days of dentistry anymore. And I hope and pray that organized dentistry will be the ones that continue to fight for us in terms of our profession and our future, because without it, we're going to be the minority and the DSOs will be the majority.
Yeah, and I'll tell you, it's. I know when you're a young kid, you think everything's woulda, shoulda, coulda, and la la land. But the bottom line is, politics is power and money, and if you don't have a seat at that table, it's not going to go well in your favor. And my only complaint about all the dental societies, I've been a member since dental school, is that they don't market what they're doing enough. I tell them all they need to have weekly newsletters about all. I mean, if you knew what was going on at the Arizona Assembly, just dental related, it's nonstop. And
right.
and who do you think's going to fight for you? The DSOs? The Delta Dental, your patients. I mean, when they talk about that they want healthcare free, what does that even mean? Are they going to arrest you when you graduate from dental school and chain you up in a government office and have you live there and do free stuff? And they go, oh, we don't want to do that. Well, then how's it free? Oh, well, we want to raise your taxes, and if you don't pay them, and then look at the taxes, government. How much tax do I owe? I don't know, but pay me now. And if you have the wrong amount, you're going to go to jail. It's like, what? And then the people want to know why they have so much
interest-free loans, right?
Yeah, and so I mean, you have to be, and also the other thing I've noticed that the most effective state dental societies is they have one guy in there who's just a politician legislator, and then another guy, the inside man, is running the nuts and bolts of the organization. But my God, it's just all politics, and you need to win that. And then what I think is the most funny is these people that are against DSOs, all those big wigs. I mean, if you own 100 or 500 or 1,000 offices, you've been on my show, they tell you which states they're avoiding because of their dental societies. And I'm like, hey, other 40 dental societies, did you just hear what he said? So I mean, go to your dental society and make me a Venn diagram of DSOs that stay out of which states and why, and then be more like that. I mean, because I am, these DSO guys, they're my buddies. I mean, a lot of them are just amazing, good dentists, but I have a serious problem. I had 4 kids, and I'm glad I never killed them, because now they've maybe 5 grandkids, which is, that's the only purpose of a child, is make you a grandchild. And when I pass on, I want them to go to a dental office that's owned by a dentist, not an MBA from Arizona State University who's publicly traded on Wall Street. I want a dentist. And every company that makes a car, the CEO is actually a mechanical engineer. And the fact that Boeing makes these, no one's even talking about the real case for this Boeing problem. Boeing management is downtown Chicago, and their planes are made in Seattle and Wichita, Kansas. That's the whole problem. You don't have MBAs in Chicago making airplanes from factories thousands of miles away. They just don't get it. The guy that's the CEO of Boeing, if he was an aeronautical engineer and a pilot, this wouldn't even be an issue. So the Boeing
And
deal.
same with the dental insurance companies. They're not dentists, right? So, but I'll get on a soapbox, and I don't want that to happen. So.
No, I love the soapbox because it's the things they don't want to talk about. It's like, it's like I had dinner with my mom yesterday, my 5 sisters, my brother. And when I sat down at the table, I got there, everybody said hi. I said, hey, let's only talk about religion and politics all through dinner. And everybody started laughing. And of course, we didn't talk about those two things because they're not pleasant. But again, you're going to pass on one day. And I want my grandchildren going to a dental office that's owned by a dentist. I want them to ride in an airplane where the boss is actually a pilot with an aeronautical engineering degree. And I want them to drive a safe car because the CEO was actually an engineer. Just imagine how simple all of this stuff sounds. Dan, we went way over time. But is there any question that I should have asked but wasn't smart enough to?
No, I just think maybe just encouraging more of the kindergartners, as you call them, the young dentists, to take the PAs before they're cementing the crowns, to really challenge the amount of tooth structure that is left, and to lay the foundation for that conversation that this tooth might need a root canal when the restorations are within 2 millimeters of the radiographic pulps. You've got to inform the patients, because otherwise the patients won't handle it well when they get surprised later on or abscess unexpectedly. So it's all about informing, just like you said, be their superhero rather than what they perceive to be the enemy that did not tell them about what might be coming. And
last question, you don't have to answer, but how do you start out in heaven in Los Angeles, California, with a beach and palm trees, and make a decision?
Well, don't remind me.
And move to Boston. I mean, you went to Harvard. What did they tell you at Harvard? Why did they tell you to go live in the frozen Cambridge area?
Well, as you know, the California dental environment is not the best. So I can't complain too much. I do miss the weather there. I miss my family, but it was a very beautiful love story, and that's why I call Boston home now.
And go to her website. It's Hopendo. It's
the shorter version is Hopendo.
Okay, Hopendo. Oh, so that's a website. If I go to Hopendo,
Hopendo works too.
Okay, I did not know that. I'm glad I said some Hopendo. Okay, but go to her website just to read her procedures or papers. I really wish you would start a thread on Dental Town, Judy, and say Howard told me to upload these PDFs, because I thoroughly enjoyed reading all of them.
I've chatted with Sam Middlestead about it, so we're working on it.
Yeah, just amazing work. But seriously,
thank you for publishing the CE on autotransplantation. That was awesome. Thank you for dedicating 10 pages to that. Whatever.
That was what was the date of that? That was what?
Last summer?
Yeah.
Fall,
Transplanting
December
molars
2018
by Dr. Judy McIntyre. I tweeted that out this morning and pushed that out again before you came on the show. But seriously, thank you for everything you've done for dentistry. Thank you for coming on the show. You got to just go to Dental Town and take her online CE course, category oral surgery, transplanting molars. And it's the course, everyone's given it a 5-star review. It's an amazing course.
Oh, awesome. I didn't even realize that. Thank you.
And
thank you for having me. I'll come back anytime and chat with you.
Well, hey, if you ever have something you want to talk about, you know my email, howard@dentaltown.com. I'd love to have you back.
Awesome. See you on Instagram.
Okay. And what's your Instagram? She is
Judy Endo.
Dr. Judy. Dr. Judy Endo. Dr. Judy Endo. That's right. Just remember Judge Judy. Dr. Judy Endo. But all right, I'll see you on Instagram. Have a great day.